Welcome back. We will continue off with different differential diagnoses of the presentations of AAION. With these symptomologies, AAION has a lot of differential diagnoses. It can be malignant hypertension, which is resistant to a lot of hypotensive meds. There could be diabetes mellitus, retinal vascular occlusion, the BRAO, compressive lesion from the back of the eye. There can be collagen vascular disease, always syphilis, as well as herpes zoster. Systemically, there can be migraine or massive blood loss that can cause these symptoms, and also normal tension glaucoma can present with decreased vision or constricted visual fields in the late stage. When taking history to rule out AAION, ask about the symptoms that have been covered on the previous slide, and also pay attention on the drug history and specifically screen for erectile dysfunction drugs and amiodarone. For medical conditions, start with open-ended questions, but ask if the patient has OSA or obstructive sleep apnea. Then, a thorough slit lamp exam to rule out any other pathologies would be helpful, and an Amsler grid to see if the visual field is coherent and there are no missing parts within the visual field would be prudent as well. But the most important part of the physical exam for AAION are the afferents and the efferents. Afferents test for the visual acuity, the color vision, which would be altered if the patient presents with dyschromatopsia, the visual fields, RAPD, and the fundus exam. The efferent exam consists of checking for extraocular movement, if the eyes are motile, looking at the alignment of the eyes in any position, comparing the size of the pupils and their reactions at the light, at the dark, and in accommodation or focusing on close-up objects. We can observe the lid for ptosis and lid lag, and lastly checking for saccades or nystagmus with Frenzel goggles would be effective and important ophthalmic exams. If you're suspicious that the patient has AAION, ESR and the CRP is crucial. We should investigate those two markers as soon as possible. In terms of vitals, we can take blood pressure. That's especially important. We can also order CVC, look for low hematocrit and high platelets as an acute phase reactant. Also look for fasting blood glucose for diabetes mellitus possibly, and VDRL and FTA absorption test for syphilis, and ANA for vascular inflammatory disease. The investigation of AAION includes a temporal artery biopsy. The biopsy is taken bilaterally and at 2 centimeter chunks. The reason that it is that way and such big biopsy is taken is because the nature of the lesions are skip lesions. So they may not be continuous along the temporal artery, and if we are unlucky, we may accidentally biopsy the normal presentation of an artery between the skip lesions. Fluorescein angiogram would also be a good test to find out if the patient has AAION, and if the FA returns with choroidal infarcts in its results, that is pretty indicative of AAION. The treatment for AAION is administering systemic steroids. So specifically methylprednisolone 1 gram IV per day times 3 days. But before we administer steroids, we will check the blood glucose as well as chest radiographs before that. The reason for that is steroids raise blood glucose and lowers the white blood cell counts. If the patient's blood glucose is high already, steroids may cause an adverse effect on the body, and therefore reducing the blood glucose before administering steroids would be important. And chest x-rays are checked to see if there are infiltrates or masses in the lungs. If the patient has pneumonia or even lung tumors, then the immune system is needed more than ever. However, steroids have an unfortunate effect of suppressing the immune system. So, knowing that patient has pneumonia or lung cancer would prompt us to adjust the treatment course or administer additional treatments to address those problems. Once the systemic steroids are cleared for administration, after the methylprednisolone for 3 days, you can give prednisone 60 to 100 milligrams per oral per day with a slow taper. We can't suddenly just stop that amount of prednisone so quickly, so we decrease by 2.5 to 5 milligrams at most per week. Because AAION is an emergency, we start before the biopsy results are returned, and H2 blockers or PPI can be given along with the systemic steroids, because systemic steroids may cause stomach ulcers. Unfortunately, AAION has quite a bad prognosis. The visual recovery is rare, and the treatment will hopefully prevent the progression of the visual impairment. And the fellow eye is also involved in 75, 3/4 of the cases, and if not treated, as quick as within 2 weeks. Here is a well-drawn flowchart to demonstrate everything that we've learned in this presentation. And here are the references for that we've used to compile all the information in this presentation. Thank you for watching this video.